All right, welcome back from lunch. So we've heard this morning that we have 6 medical aid in dying statutes in the United States. We heard this morning that they're all based closely on the model of Oregon, and that all 6 statutes are nearly identical. We also, both in terms of the eligibility requirements and in terms of safeguards. We also know that we have bills in more than half of the states in this country, and those bills basically would propose to legalize medical aid in dying, and they're also nearly identical to the 6 statutes that already exist. So in the next 12 minutes, here's what I'm going to do. I'm going to ask whether or not those safeguards, which are in the existing 6 statutes and which are in almost every bill which will propose additional statutes, whether those safeguards and eligibility requirements are too weak, and also whether or not they are too strong. Now, I'm not going to present my arguments. These are not my arguments. These are not my positions. I was asked not to do that. What I'm going to present is just data. Just objective presentation of data about what institutions and what legislatures are in fact doing. Okay, so in terms of the current safeguards being too weak, and this is going to synergize with a lot of what we heard this morning, I actually only have one good example of the safeguards potentially being too weak. So in every one of the current 6 statutes, you are ineligible for medical aid in dying if you have impaired judgment due to a mental disorder, as we heard. And that makes sense, right? We want to make sure that the decision is voluntary. But here's the problem. How exactly is it that we screen for that impaired judgment due to a mental disorder? As we heard, you are referred to a mental health specialist only if the attending or consulting refers you for that. And that doesn't happen very much. So the latest data from Oregon, which was published on Friday, shows that it's less than 5% of the patients who receive prescriptions are referred for that screening. And in fact, that's been dropping over time. That's the cumulative 20-year figure. And then if you look at the Washington data, it's pretty much the same. So many think, and we heard this already in today's sessions, that many think that that referral rate is too low. Therefore, some institutions at the institutional level, it's not required by the law, but some institutions at the institutional level require a mental health screening for everybody, what you might call an automatic mental health screening, not just by referral. And sometimes if you look around, some people have sought to put this into laws. So in Scotland, this law didn't pass, but that was built into the bill that there was going to be an automatic mental health screening in the Scottish law. In the Belgian law, there is an automatic mental health screening currently, but it's only for some categories of patients if you're not terminally ill or for the mature minors. So they have a broader eligibility requirement, and at least for those 2 categories of patients, they do need to get a mental health screening. So the question is, are we failing to screen out some people with impaired judgment who shouldn't be getting the prescription? Well, there's actually no proof of that. I think that was the outcome of some of the earlier speakers, but it definitely needs study because it's a potential risk. So basically, there's no good evidence that I could find that the safeguards are too weak. So I wanted to spend the balance of my time talking about ways in which the current safeguards and eligibility requirements may be too strong. And I want to give you 6 examples. So there's a terminal illness requirement, right? All 6 statutes require, as we heard, that the patient have an incurable and irreversible condition that will cause death within 6 months. But that's pretty temporally strict. And there are many people who, at least in their own judgment and estimation, are suffering unbearably, but they're not terminally ill. And so they would be excluded in the United States. So the American College of Physicians, for example, which has a position statement on what they call physician-assisted suicide, and this position statement is absolutely opposed to medical aid in dying. But the point is, at least in the argumentation for that, they say it's arbitrary to limit it to people who are terminally ill. And I think that may be right. And it's worth noting, so again, I'm just presenting data about what other people are doing. The most recent medical aid in dying law in the world passed a few weeks ago in Victoria, Australia. And this is a tweet by the Premier of Victoria. So by the way, there's other world leaders that tweet a lot. So he tweeted, right, this is the most conservative voluntary assisted dying model in the world, the most conservative in the world. And even the Victoria model extends to 12 months, not just 6 months, extends to 12 months at least for neurodegenerative illnesses. In Canada already, they've completely dropped, as we heard, the time requirement altogether. And so instead of having 6 months, 12 months, death only needs to be reasonably predictable. And that's, and in the Benelux countries, similarly, no temporal limitation at all on access. Okay, that's a terminal illness requirement. There's a self-ingestion requirement, right? So all 6 statutes in the United States require that the physician only prescribes the medication, the patient administers it. And that, we understand why that's there. It helps assure voluntariness. If you take it yourself, then you must have really wanted to take it. But some people lose the ability to self-ingest the medication. And also, some people have complications from self-ingestion. So again, if we look at the latest Oregon data published on Friday, you see that there is a 3 to 6% complication rate, whether due to regurgitation or waking back up or seizures or other complications. And that seems significant. And those complications may rise, I mean, some people have written about this too, because we're now moving away from segobarbital and using new drugs which don't quite have the same track record. Now, those complications can be avoided and are avoided with clinician administration. So in Canada, and it's called MAID, medical aid in dying in Canada, more than 2,000 patients have obtained medical aid in dying in Canada. Only 5 of those 2,000 have self-ingested the medication. The other 1,995, it was physician administered. And avoided complications, as we see in Oregon and Washington. Also, in the Benelux countries, also allows physician administration. In Victoria, the most recent law, it is like the United States. It's normally to be self-administered, as in the 6 US states, but physician administration is allowed in Victoria if the patient is physically incapable of self-administration or digestion. So there's a presumption for self-ingestion, but it can be rebutted. Third safeguard, the adult requirement. So in the 6 US states, you have to be 18 years or older to obtain the medication. And of course, that's there to assure that it's voluntary and informed. But we allow minors in many, many US states to make other healthcare decisions, life and death healthcare decisions about life-sustaining treatment. And so many have written, like the American College of Physicians, it's an arbitrary distinction to limit it to adults, but not to mature minors. In Canada, they legalized the law in 2 stages. Right now in Canada, right now it's limited to adults. So right now it's the same as the United States. But later this year, Parliament's going to come back and work on stage 2, and one of the agenda items for stage 2 is extending it to mature minors. And the Benelux, at least 2 of the Benelux countries already allow mature minors to access medical aid in dying. Fourth safeguard, capacity. All 6 statutes in the United States require that the request be made solely and directly by the individual, not by advance directive. But what about dementia, right? For people with dementia, by the time you are terminally ill, you're not going to have capacity anymore. And so again, American College of Physicians says this is an arbitrary distinction to allow the decision contemporaneously, but to not allow it to be made through an advance decision. And in fact, the Supreme Court of Alaska said it would actually be unconstitutional to allow medical aid in dying contemporaneously, but to not allow it by advance decision. In Canada, this is again one of the stage 2 agenda items. Later this year, Parliament will come back and consider whether to expand medical aid in dying through advance directive. Already allowed in all the Benelux countries. Fifth, the waiting period. All 6 US statutes require that there be multiple requests for the medication separated by a certain period of time. And that's a good idea, right? We want to ensure that the request is enduring and settled and deliberate. But many have written that imposes an undue burden on some patients. So in Victoria, for example, they address this a little bit in the new law, which is they will waive the waiting period if there's a certification that the death is likely to occur before the expiration of the waiting period. Then you don't have to go through the waiting period. And then finally, the physician requirement. All 6 statutes in the United States require, right, that you be certified, all the eligibility requirements be certified both by an attending and by a consulting physician. And that attending and consulting physician must be an MD or DO licensed in that state. But many have written that there are big and serious access problems with finding an available and willing physician. So there has been an increasing literature on whether or not we should expand medical aid in dying, the clinicians, to also include nurse practitioners. It's worth noting, by analogy, with POLST, right? Many states have POLST laws. Most of the time when those POLST laws were first enacted, the only people who could sign a POLST was an MD and a DO. Almost without fail, every one of those states subsequently 2, 3, 4, 5 years later went back and amended it to also allow NPs to sign POLST. Why? Because hardly any POLSTs were getting signed, and we think it's a valuable tool. We should expand it. So in Canada, already NPs are permitted clinicians in Canada, and at least in some US states, there have been bills to allow NPs to participate in medical aid in dying here. Thank you.